take a breath right now. Seriously. Wherever you are, just inhale.
Yeah, notice how your chest expands, how your shoulders might, lift a fraction of an inch.
Right. And how the air feels cool hitting the back of your throat.
Yeah.
You take roughly, well, 20,000 of those breaths every single day.
At least.
And if you're like most people, you never even think about it until the exact moment you can't.
It's the ultimate invisible engine. I mean, we treat breathing as this completely automatic background process.
Totally.
We ignore the most vital mechanical rhythm happening inside our bodies until, the biological check engine light comes on and suddenly we're gasping.
Well, welcome to the deep dive. Today is Friday, March 13th, 2026, and we are cracking open the incredibly intense, frankly, terrifyingly fragile world of pulmonary medicine.
It is a wild landscape.
It really is. We have this massive clinical textbook on respiratory and pleural disorders, and our mission for this deep dive is to map out the microscopic tissues, the extreme pressure vacuums, and, the invasive threats that can shut down that invisible engine.
Right. We're going to explore how the human respiratory system fails, how it's attacked by invisible invaders or physical trauma.
And the incredible, sometimes extreme mechanical interventions that medical professionals use to just keep us breathing when our bodies give up.
What stands out when you look at the clinical reality of pulmonary care is that it isn't just about the pathology of a disease. No, it's about the pure physics of survival. We're dealing with how pressure, volume, and anatomy have to perfectly align within a closed system.
That closed box of the chest.
Exactly. And more importantly, we are looking at the catastrophic cascade of events that happens when that delicate physical balance is violently disrupted.
And whether you are a medical professional stepping into your first clinical rotation or just someone who is insanely curious about the miraculous high-stakes biology happening inside your own chest every few seconds, we are tailoring this deep dive entirely for you.
I'm genuinely looking forward to this.
Me too. And to help me navigate this incredibly dense, complex landscape, I have the ultimate expert guide to the respiratory system here with me.
Thank you. If we connect this specific anatomy to the bigger picture of human health, every single cell in your body, from your brain to your toes, relies on the continuous exchange of gas happening in your chest right now.
That's a huge thought.
It is.
Yeah.
When that exchange goes wrong, literally everything goes wrong.
So let's start at the microscopic level. Before we get to the massive life support machines and, major blunt force chest trauma, we really need to understand the most common, everyday ways our lungs begin to fail.
The everyday failures, yeah.
I want to picture the very end of the airway. So you breathe in, the air travels down the trachea, it splits into the bronchi and goes deep into the lung tissue. At the very end of those tiny branches, what are we actually looking at?
You're looking at the alveoli.
Okay.
Imagine millions of microscopic, incredibly thin-walled, wet balloons. They're clustered together like bunches of grapes at the very end of the tiniest airway tubes, which are called bronchioles.
Millions of wet balloons.
Exactly. And these alveoli are where the actual magic of gas exchange happens. Oxygen crosses their super thin walls into your bloodstream, and carbon dioxide crosses back into the balloon so it can be exhaled.
So we have these millions of wet balloons.
Yeah.
What happens when they fail? I mean, I've seen the term atelectasis thrown around constantly in respiratory charts.
Atelectasis is arguably one of the most commonly encountered abnormalities you'll see on a chest X-ray. Fundamentally, it refers to the closure or the collapse of those alveoli.
They just close.
Right. The wet balloons stick together, they completely deflate, and they refuse to reinflate.
How does that actually happen physically? Are they, being crushed from the outside?
It generally falls into two mechanical categories, non-obstructive and obstructive.
Okay, let's break those down.
So non-obstructive is fairly straightforward. It occurs simply as a result of reduced ventilation. You just aren't taking deep enough breaths to stretch the lung tissue and keep the balloons inflated.
Like when you're just sitting still for hours?
Exactly. But obstructive atelectasis is where the physics of the human body get really fascinating and a bit scary.
Obstructive sounds like something is actually blocking the path. Like a cork in a wine bottle?
Think of it mechanically like that, yeah. A mucus plug forms and blocks a small airway leading down to a cluster of alveoli.
Okay.
So no new air from the outside can get past that plug, but the trapped alveolar air doesn't just sit there suspended. The pulmonary capillaries surrounding those balloons are still flowing with blood.
Wait, really? Gas exchange is still occurring?
Precisely. The blood is actively pulling oxygen out of the trapped air inside the balloon. The blood absorbs the trapped gas.
Oh, wow.
But because of the mucus plug, no new air can rush in to replace the volume that was just absorbed into the bloodstream.
So the balloon just empties out.
Yes. As the gas is siphoned away, the physical volume inside the alveolus drops, the pressure drops, and the balloon literally deflates and collapses in on itself.
That is wild. The blood literally steals the structural integrity of the lung.
It's exactly what happens. That affected portion of the lung becomes completely airless and essentially useless.
So who is most at risk for this kind of microscopic collapse?
Anyone recovering from surgery. The postoperative period is a perfect storm of respiratory risk factors.
Why surgery specifically?
Consider what happens to a human body during and after a major operation. First, you have the lingering systemic effects of general anesthesia and really potent analgesic agents like opioids.
Right, the heavy painkillers.
Yeah. These drugs naturally depress the central nervous system's respiratory drive. The patient falls into this monotonous, low tidal volume breathing pattern.
They're taking really shallow sips of air.
Exactly. And that shallow breathing directly causes small airway closure, the non-obstructive atelectasis we just talked about.
Okay.
Then you have the physical positioning. The patient is usually lying flat on their back in a supine position for prolonged periods. So gravity is compressing the posterior parts of the lungs.
The back of the lungs are getting squished.
Right. Add to that the splinting of the chest wall because of incisional pain.
Splinting, you mean like they are bracing themselves against the pain?
Yeah, when a patient has a surgical incision on their abdomen or chest, it hurts immensely to stretch that tissue.
I can imagine.
Taking a deep breath stretches the tissue.
Yeah.
So the body subconsciously refuses to do it. The patient voluntarily limits their chest extension.
Just to avoid the pain.
Exactly. And finally, because they aren't taking deep breaths, they also aren't generating enough force to cough effectively.
Which leads back to the mucus.
Right. Without a strong cough, normal daily secretions pool in the airways, creating those exact mucus plugs that trigger the obstructive collapse we just detailed.
It sounds like a cascade of respiratory failure just waiting to happen from something as simple as, I don't know, lying in a hospital bed after getting your appendix removed.
It really is.
How do medical teams fight against that perfect storm?
Well, hospitals have designed a brilliantly simple, standardized battle plan for this. It's often referred to by the acronym ICOUGH.
ICOUGH.
Yes, the word cough with an I in front of it. It represents a multidisciplinary approach to forcing the lungs back open and keeping the airways clear.
Break down the acronym for me. I'm assuming the C is for cough.
Ooh, let's run through it.
Huh?
I stands for incentive spirometry.
Okay.
C is for coughing and deep breathing exercises. O is oral care, meaning brushing the patient's teeth and using mouthwash twice a day.
Wait, brushing teeth helps the lungs?
Oh, absolutely. It drastically reduces the bacterial load in the mouth that could be accidentally inhaled.
Oh, that makes sense.
U stands for understanding, meaning patient and staff education about why these painful exercises are vital.
Getting buy-in from the patient.
Right. G is getting out of bed at least 3 times a day to let gravity help expand the lungs. And H is head of bed elevation.
Sitting them up.
Exactly.
I want to focus heavily on that first letter, though. Incentive spirometry.
It's crucial.
I remember seeing these plastic devices in hospital rooms. It seems incredibly low-tech compared to all the monitors and IV pumps. You're basically handing the patient a clear plastic tube with some little colored balls inside it. How does that prevent a lung from collapsing?
It's wonderfully effective because it leverages immediate, indisputable visual feedback to overcome that subconscious shallow breathing we talked about.
Okay.
The goal of an incentive spirometer is to ensure that the volume of air inhaled is increased gradually as the patient takes deeper, slower, and more sustained breaths.
So it's not about blowing into it as hard as you can.
That is a very common misconception. It's entirely about inhalation. You want the patient to suck the air in, sort of mimicking a deep sigh or a yawn.
Interesting.
There are 2 main types of spirometers, volume and flow. Volume spirometers have a preset target, and the patient inhales until a specific volume is reached. But the flow type is the classic one you mentioned, with the movable plastic balls.
Was it just hover in the chamber?
Yeah, the spirometer contains those little balls that are pushed upward by the force of the negative pressure from the breath. They are held suspended in the air while the patient maintains a slow, deep inhalation.
It's like a game.
It really is. The amount of air inhaled and the flow rate are estimated by how long and how high the balls remain suspended. The nurse usually instructs the patient to do this about 10 times in succession every single hour they are awake.
10 times an hour. That sounds exhausting for someone who just had major surgery.
It's a localized workout just for the intercostal muscles and diaphragm for sure.
But I guess the payoff is worth it.
The biological payoff is massive. By forcing that maximal lung inflation, the negative pressure literally pops those sticky, collapsed alveoli back open. It increases the functional residual capacity of the lungs.
It reinflates the balloon.
Yes. Plus, that deep, sustained stretch almost always triggers the C in the acronym a productive cough, which helps clear out any forming mucus plugs.
Speaking of coughing and mucus, we need to look at another major threat that attacks the airways before it even reaches the alveoli. Acute tracheobronchitis.
Yes, moving up the airway.
Right. We're moving from the tiny microscopic balloons up into the larger tubes of the respiratory tree.
Tracheobronchitis is a severe acute inflammation of the mucous membranes lining the trachea and the bronchial tree. It very often follows a viral infection of the upper respiratory tract.
Like a cold.
Exactly. Your typical bad cold moves down into your chest. The mucosa becomes inflamed and engorged, and it begins producing mucopurulent sputum.
Mucopurulent, that just sounds thick.
It is an incredibly thick, sticky, pus-filled mucus. The body produces it as an inflammatory response, basically trying to trap the invading pathogens. But it becomes a huge physical hazard in the airway.
Now, I have to confess a personal habit here, and I want you to tell me exactly why it is a terrible idea.
Oh, boy.
When I get a brutal chest cold, the kind where you have a dry, hacking, painful cough that keeps you awake all night, my immediate instinct is to go to the pharmacy and buy a heavy-duty, over-the-counter antihistamine to dry everything up and just stop the coughing.
Yeah, clinical guidelines strongly advise against that exact impulse.
Really?
Taking an antihistamine for acute tracheobronchitis is fundamentally counterproductive to your body's recovery.
But why? If I'm drowning in mucus, shouldn't I try to dry it up?
It comes back to the physical properties of that purulent sputum. Antihistamines, by their pharmacological nature, cause excessive systemic drying.
Right, they dry you out.
If you dry out the fluid component of that thick, pus-filled mucus lining your bronchial tree, you don't make it magically disappear, you just remove its moisture.
Oh, no.
It becomes incredibly viscous, tenacious, and hard. It essentially turns into glue coating the inside of your lungs.
Oh, wow. So instead of a liquid I can cough out, I've created a permanent sticky coating inside my chest.
It becomes nearly impossible to expectorate. Your cilia, the tiny hair-like structures trying to sweep the mucus up and out of your lungs, they just cannot move it.
They're stuck in the glue.
Exactly. Copious, purulent secretions that cannot be cleared by coughing place you at severe risk for increasing airway obstruction. Worse, it traps the bacteria or viral particles deep down in the lungs, giving them a perfect, warm, dark environment to multiply.
That's horrifying.
What started as an irritation in the tubes can rapidly descend into a much more severe lower respiratory tract infection.
Like pneumonia.
Exactly. Instead of antihistamines, the actual clinical treatment is to aggressively increase your fluid intake.
Drink more water?
Yes, you want to hydrate the body to thin those secretions out, making them watery enough to cough up easily. Medical teams might also use cool vapor therapy or steam inhalations to reduce the airway irritation, but the primary goal is always to expel the mucus, never to dry it in place.
Okay, that changes how we'll treat every chest cold from now on.
Right.
Don't turn the mucus to glue. Thin it out and get rid of it.
It's the only way.
Because if we don't, we invite the heavy hitter of respiratory diseases. Let's move deeper into the lungs. If tracheobronchitis is the irritation of the plumbing, pneumonia is the invasion and destruction of the lung tissue itself.
Pneumonia is an incredibly complex, devastating disease process. It's defined as an inflammation of the lung parenchyma, the actual functional tissue of the lungs, including the alveoli caused by microorganisms.
Bugs in the lung tissue.
Right. We're talking about bacteria, mycobacteria, fungi, or viruses. To grasp the scale of this threat, consider that pneumonia, often grouped with influenza, consistently ranks among the most common causes of death from infectious diseases globally.
It's a massive killer. Now, I noticed that medical charts never just say pneumonia. They always attach an acronym to it based on where the patient was when they got sick. Why do doctors care so much about the geography of the infection?
Because the location where the patient contracted the disease is the strongest predictor of which specific microorganism is attacking them. And knowing the organism dictates the exact weapon you use to fight it. Broadly, the medical community categorizes pneumonia into 4 distinct classifications: CAP, HCAP, HAP, and VAP.
Break those down for me. Let's start with CAP.
CAP is community-acquired pneumonia. As the name implies, it occurs in the community setting or within the first 48 hours after a patient is admitted to the hospital.
So it means they brought the bug in with them from the outside world.
Exactly. The most common bacterial culprit here is Streptococcus pneumonia.
This is the standard bug floating around the grocery store or the office, the one our immune systems see relatively often.
Correct. It is a serious illness, but the bacteria are generally susceptible to standard first-line antibiotics.
They're easy to kill.
Relatively, yes. But then we have HCAP, which is healthcare-associated pneumonia.
Healthcare-associated, how is that different from hospital-acquired?
This is a vital distinction. This occurs in a non-hospitalized patient, but someone who has had extensive recent contact with the healthcare system.
Like who?
Think of a resident in a long-term care facility, a patient who goes to a clinic for hemodialysis 3 times a week, or someone who recently received intravenous antibiotic therapy at an infusion center.
Why does spending time in an outpatient clinic change the nature of the pneumonia?
Because of the evolutionary pressure we put on bacteria in those specific environments, healthcare settings are where we use the most antibiotics.
Ah, so the bugs there are tougher.
Exactly. The bacteria that survive in those environments are the toughest. They're often MDROs, multi-drug-resistant organisms.
Superbugs.
Right. If a patient gets sick from a healthcare environment, the physician has to assume they're dealing with a bug that has already learned how to defeat our common drugs.
Which brings us to HAP, hospital-acquired pneumonia.
This develops 48 hours or more after a patient is admitted to the hospital for something else entirely. It is a massive clinical challenge.
How bad is it?
It is the most common cause of death among all patients with hospital-acquired infections, carrying mortality rates that can reach up to 33%.
Wait, 33%? 1 in 3? Why is it so deadly? Are hospitals just covered in superbugs?
It's a combination of highly virulent bacteria and highly vulnerable hosts.
Okay.
Hospitalized patients are often already severely ill, meaning their immune defenses are impaired. They're exposed to pathogens via respiratory therapy devices through the microscopic droplets on healthcare personnel's hands or from the hospital environment itself.
And the bugs are resistant.
These bugs are highly aggressive, often strains like MRSA or Pseudomonas aeruginosa, which require incredibly potent, sometimes severely toxic, intravenous antibiotics.
And the final acronym is VAP, ventilator-associated pneumonia.
VAP is technically a subtype of hospital-acquired pneumonia, but it specifically develops 48 hours or more after a patient is intubated.
When they have the breathing tube in.
Yes. When you insert a plastic endotracheal tube down a patient's throat and into their trachea, you are physically bypassing all of the body's natural upper airway defenses.
Right, the nasal hairs, the mucous membranes, the gag reflex, the cough.
All of it is bypassed. You are providing a direct, open plastic highway for bacteria to travel straight from the outside world into the sterile environment of the lower lungs.
Okay, regardless of how the bacteria get there, let's look at what they actually do.
Right.
Once the bacteria settle into the alveoli and start multiplying, the body responds with massive inflammation.
Massive.
The alveoli flood with exudate fluid, white blood cells, dead bacteria. When a patient's lung is flooded like that, how does it affect the blood flowing past it?
This creates one of the most fundamental concepts in all of respiratory physiology, the ventilation-perfusion mismatch, commonly referred to as a VQ mismatch.
I see VQ mismatch everywhere in pulmonary discussions. What do those 2 letters actually represent?
V stands for ventilation. This represents the flow of air reaching the alveoli.
Yep.
Q stands for perfusion. This represents the flow of blood reaching the alveoli via the pulmonary capillaries.
Got it. V is air, Q is blood.
In a healthy lung, there's an intricate balance. The ratio of ventilation to perfusion is usually around 0.8, meaning the body brilliantly routes the right amount of air to meet the right amount of blood to optimize gas exchange.
Let me try an analogy here to see if I'm tracking this.
Sure.
Imagine the capillary is a train track, and the red blood cells are empty boxcars arriving at a train station. The alveolus is the train station, and the air you breathe in is the cargo, the oxygen.
I like this.
In a healthy lung, the empty train arrives at the station. The station is full of oxygen cargo. They make the swap, the carbon dioxide is unloaded, the oxygen is loaded onto the train, and it speeds away to the rest of the body.
That is an excellent visualization. Now, apply the pathology of pneumonia to that train station.
Okay.
The bacterial infection triggers an inflammatory cascade. The alveolar station physically floods with thick inflammatory exudate. The station is basically underwater.
So no cargo can get in.
Right. So ventilation, the V plummets to near zero in that specific area. No new oxygen cargo can get into the station.
But the train is still running.
The perfusion is still happening. The heart is still pumping blood through that capillary bed. The train of empty, deoxygenated red blood cells arrives at the flooded station.
And there's nothing to pick up.
There is no oxygen cargo to pick up. So the train simply rolls right past the station, completely empty, and continues its journey back to the left side of the heart.
So you have a massive volume of deoxygenated blood mixing back in with whatever oxygenated blood managed to come from the healthy parts of the lung.
Yes. This physiological shunting of unoxygenated blood directly into the systemic circulation is what causes arterial hypoxemia. The oxygen levels in the patient's arteries drop precipitously.
Starving the brain and organs.
Yes, starving them of the oxygen they need to survive. It is a mechanical failure of supply and demand.
And it isn't always an airborne bug that causes this massive flooding. There is a deeply unsettling covert threat called aspiration pneumonia. It seems like the body attacking itself.
Aspiration is a major focus in clinical care. It's defined as the inhalation of foreign material into the lungs. Most commonly, people microaspirate tiny amounts of bacteria that normally reside in their upper airways or throat.
Which is bad enough.
But the most catastrophic form is the aspiration of gastric contents stomach acid.
How does stomach acid get all the way up the esophagus and down into the sterile lungs? Doesn't the body have intense reflexes to prevent that? I mean, if I swallow a drop of water the wrong way, I cough violently for 5 minutes.
A neurologically intact, healthy person has a robust gag reflex and a violent cough reflex precisely to guard the airway. But aspiration becomes a lethal threat when those protective reflexes are decreased or entirely absent.
When does that happen?
This occurs in patients who have suffered a stroke, a traumatic brain injury, drug or alcohol intoxication, or those who are under heavy sedation in a hospital.
So they can't cough.
If a patient with suppressed reflexes has a full stomach and they are lying completely flat, gravity is no longer keeping the stomach contents down. Gastric juices can silently regurgitate, pool in the back of the throat, and slip right past the vocal cords down the trachea.
And human stomach acid has a pH of around 1.5 to 3.5. It is designed to dissolve meat. If that hits the delicate one-cell-thick walls of the alveoli,
it is chemically destructive. During fasting, gastric juice is highly acidic. If aspirated, it causes immediate chemical pneumonitis.
it burns them.
It physically burns and destroys the alveolar lining and the adjacent capillary membranes. The lung tissue swells, bleeds, and fills with fluid.
That's horrifying.
And this severe chemical burn then drastically impairs the lung's immune defenses, turning the damaged tissue into a perfect breeding ground for massive secondary bacterial growth.
So a patient can literally drown in their own inflammatory response to their stomach acid. That totally explains why hospital beds always seem to be tilted up slightly.
That is the exact clinical countermeasure. Nurses are hypervigilant about keeping the head of the bed elevated at least 30 to 45 degrees for any patient who cannot adequately protect their airway.
Especially those receiving tube feedings.
Exactly. It uses simple gravity to keep the acid in the stomach where it belongs.
Now, we cannot talk about severe diffuse viral pneumonia without looking at the massive paradigm shift of the 2020s. COVID-19 rewrote vast sections of pulmonary understanding.
It absolutely did. The pathophysiology of SARS-CoV-2 is unique and devastating. The virus doesn't just randomly attack lung tissue, it operates like a master safecracker.
Oh, so?
It enters host cells by specifically binding to ACE2 cellular surface receptors.
I've heard of ACE2. Why are those receptors so critical in the lungs?
Well, ACE2 receptors are present in various tissues, but they are incredibly abundant on the surface of type 2 alveolar cells.
Type 2 cells. Wait, those are the specific cells that act as factories to produce surfactant, right?
Yes.
The slippery, soap-like substance that coats the inside of the wet balloon so they don't stick together?
You have the exact mechanism. The virus specifically targets, hijacks, and destroys the very cells responsible for keeping the lungs compliant and open.
So the soap factory shuts down.
As the virus replicates, it causes widespread death of these type 2 cells. Surfactant production crashes, the alveoli collapse.
And the immune system freaks out.
The immune system overreacts, triggering a massive cytokine storm, a flood of inflammatory chemicals that causes the capillaries to leak violently.
It floods the lungs.
If you look at a chest x-ray or a CT scan of a severe COVID-19 patient, you don't just see one lobular consolidation like standard pneumonia.
Yeah.
You see diffuse bilateral ground glass opacity spread across both lungs.
Ground glass.
It looks like someone took a handful of shattered white glass and scattered it across the lung fields.
But the physical symptoms didn't always match the terrifying X-rays. There was a phenomenon early in the pandemic that confused doctors worldwide. They called them the happy hypoxemics. What was happening there?
It was a truly baffling and chilling clinical presentation. Hypoxemia, as we discussed, is a dangerously low level of oxygen in the blood. Under normal physiological rules, when your arterial oxygen tension, your PaO2, drops to a critical level, your brain's chemoreceptors sound a massive, unavoidable alarm. You experience severe dyspnea.
Dyspnea is that intense, panicky feeling of air hunger, like you are suffocating and need to gasp.
Yes, a patient with a blood oxygen saturation in the 70s or 80s should look and feel like they are drowning. They should be distressed, breathing rapidly, and fighting for air.
Right.
But with the happy hypoxemics in COVID-19, patients presented to emergency rooms with dangerously low, sometimes life-threatening oxygen saturation levels, yet they reported absolutely no dyspnea.
They felt fine.
They were sitting up in bed, looking at their phones, scrolling social media, speaking in full sentences without pausing for breath.
Their brains were entirely unaware that their organs were starving for oxygen.
Exactly.
How is that even biologically possible? How does the brain not know the blood is empty?
The exact neural mechanisms are still a subject of intense research, but several factors are believed to play a role. Some researchers hypothesize that the virus might directly infect and interfere with the brain's hypoxia-sensing mechanisms in the carotid bodies or the brainstem.
It hacks the sensors?
Alternatively, it might be related to lung mechanics. In early COVID pneumonia, the lungs often remain surprisingly compliant. They're still relatively stretchy, unlike the stiff lungs in later stages.
Right.
Because the physical work of expanding the chest doesn't feel drastically increased, the brain doesn't register the distress, even though gas exchange at the alveolar capillary membrane is failing miserably.
It's terrifying because if you don't feel sick, you don't seek help until it's too late. It's a silent hypoxia.
And it makes them incredibly dangerous to manage because these patients can appear completely stable one moment and then crash into sudden, catastrophic respiratory failure minutes later without any of the classic warning signs.
Dealing with that level of unpredictable physiological collapse during a global surge placed unimaginable strain on the medical system. And exploring this topic forces us to look beyond just biology and into the societal and ethical realities of healthcare.
That's very true.
There is a specific clinical scenario often discussed regarding nursing during severe resource shortages. It outlines a staff nurse working in a medical intensive care unit who reaches a breaking point and refuses to care for COVID-19 patients.
It's a profound, raw, and very necessary discussion about the ethics of care during a crisis. The scenario details a hospital that is completely overwhelmed. Personal protective equipment, or PPE, is being severely rationed.
Right.
New administrative policies are forcing the frontline staff to reuse N95 masks for days, or use alternative, less effective gear in ways that prior to the pandemic would have been considered severe occupational safety violations.
So the nurse is looking at a highly infectious, deadly virus, looking at a reused, degrading mask, and essentially says, I am not going to risk my own life or my family's life. Find me a safer ward to work on, or I resign.
This scenario is used to rigorously explore the collision of foundational ethical principles. On one side, you have the deeply ingrained professional principle of beneficence.
Beneficence.
This is the fundamental duty of a healthcare provider to do good, to act in the best interest of the patient, and during a mass casualty event or pandemic, to do the greatest good for the greatest number of people. It is the oath to heal.
But opposed to that duty, you have individual rights and self-preservation.
Precisely. Do healthcare workers forfeit their right to a safe working environment when they take the job? Do they have the ethical right to refuse care if they legitimately believe their own physical safety is being recklessly compromised due to institutional failures to provide adequate protective gear?
It forces you to weigh variables that have no easy metric. I mean, does a healthy 25-year-old nurse who lives alone have a different ethical obligation to step into that room than a 60-year-old nurse who has underlying asthma and goes home every night to care for an immunocompromised spouse?
The discussion doesn't offer a simple binary answer. Instead, it forces professionals to critically analyze how the duty to provide care intersects with personal risk, boundaries, and the moral injury that occurs when the system fails to protect the protectors. It highlights that severe respiratory diseases don't just destroy lung tissue, they can fracture the very infrastructure of healthcare.
It's a heavy reality to sit with. But we need to shift our focus back into the body to a different kind of invader. Not all lung threats flood the system quickly and violently, like a pandemic virus or stomach acid. Some of them play the long game.
The stealth invader.
They are patient, stealthy, and incredibly persistent.
Let's look at covert threats in chronic battles, specifically the ancient enemy tuberculosis.
Tuberculosis, or TB, is a masterclass in biological stealth and endurance. It's caused by the bacterium Mycobacterium tuberculosis. Despite being an ancient disease, it remains a massive global health crisis, with thousands of cases reported annually even in highly developed nations. And its method of invasion is purely airborne. Usually when we talk about airborne spread, we talk about coughing and sneezing heavy droplets that fall to the ground within a few feet. But TB is different. It travels in something called droplet nuclei. What is the distinction?
It's a crucial physical distinction. When a person with active TB talks, laughs, sneezes, or coughs, they expel droplets. But the moisture in these tiny droplets quickly evaporates, leaving behind a microscopic particle called a droplet nucleus.
Okay, so just the nucleus.
These particles are incredibly small, usually only 1 to 5 micrometers in diameter.
Because they are so small and lack the weight of water, they don't fall.
They defy gravity. They remain suspended in the ambient air currents for hours, sometimes days, long after the infected person has left the room.
Wow.
If a susceptible person walks into that room and inhales that shared air, those microscopic nuclei are so small they bypass the mucus traps of the upper airway and travel deep, straight into the terminal alveoli.
And once they land in the alveoli, a microscopic, decades-long war begins. The cellular response is fascinating. It's essentially a cellular siege. A biological fortress is built.
A siege is the perfect metaphor. When the TB bacteria land, the body's immune system immediately recognizes the foreign invader. It deploys its frontline defenders, the macrophages.
The cellular garbage trucks.
Exactly. These are large, white blood cells that act like garbage trucks. Their job is to literally engulf, swallow, and digest foreign particles.
So the macrophage eats the TB bacterium. Problem solved, right?
In a normal infection, yes. But Mycobacterium tuberculosis has evolved a brilliant defense. It possesses a thick, waxy cell wall rich in mycolic acids.
Waxy armor.
This waxy armor completely resists the destructive enzymes inside the macrophage. So the macrophage swallows the bacterium, but it cannot digest it. The bacteria simply survive and slowly multiply inside the macrophage itself.
It uses the immune system's own garbage truck as a Trojan horse.
Exactly. Recognizing that the frontline defense has failed, the immune system panics and initiates a massive, localized inflammatory reaction.
Calling for backup.
It summons waves of other immune cells, more macrophages, T lymphocytes, and fibroblasts to the site. Realizing they cannot kill the bacteria, these immune cells change their strategy from destruction to containment.
That wall them in.
They literally build a dense, fibrous wall of scar tissue completely surrounding the infected macrophages.
They build a fortress?
This fibrous tissue mass is called a granuloma, or specifically in TB, a Goen tubercle. Inside this heavily fortified, walled-off area, the environment becomes highly toxic.
What happens to the bacteria inside?
The trapped macrophages die, and the core of the tubercle turns into a soft, cheesy, necrotic mass. Over time, the outer wall of this fortress may calcify, turning into a hard nodule that shows up brightly on an X-ray.
So if the bacteria are trapped inside a calcified scar, does the patient feel sick? Has the body won?
The body has achieved a tense stalemate. At this point, the patient has what is called latent TB infection. They have no symptoms, they are not contagious, they feel completely healthy. But the chilling part is that the bacteria inside that cheesy core are not dead. They are merely dormant, pushed into a state of suspended animation. They can survive inside that calcified fortress for decades, just waiting for the surrounding wall to weaken.
And what causes the wall to weaken?
Anything that suppresses the patient's immune system. As the person ages, or if they undergo chemotherapy for cancer or contract HIV, the immune cells maintaining that fibrous wall begin to fail.
The wall crumbles.
The wall crumbles.
Yeah.
The Goen tubercle ulcerates.
Yeah.
The cheesy, bacteria-filled necrotic material liquefies and bursts into the surrounding bronchi.
And the bacteria wake up.
The dormant bacteria suddenly wake up, multiply rapidly, and the patient develops active, highly infectious pulmonary tuberculosis, complete with fever, night sweats, and coughing up blood.
It's an incredibly insidious timeline. So how does medicine even detect this silent fortress before it ruptures? Medical professionals rely heavily on the PPD skin test or the Mantoux test.
Yes, the purified protein derivative test. It's a brilliant utilization of the body's own immune memory.
How does it work?
A tiny standardized amount of tubercle bacillus extract, just the proteins, not live bacteria, is injected intradermally, just under the top layer of skin on the inner forearm.
I always assumed that if the skin turned bright red and looked irritated, it meant you were positive. But the medical criteria are incredibly specific about what actually counts as a positive reaction. They don't care about the redness, they care about something called induration. What is the difference?
This is a classic diagnostic trap. Erythema, which is simply redness or a flush of the skin, can happen for a dozen reasons, including just the physical irritation of the needle. Redness without induration is clinically insignificant.
Okay, so what is induration?
Induration is a palpable, raised, hardened area of tissue. The nurse or doctor must lightly sweep their fingers over the injection site 48 and 72 hours later to physically feel for a hard, dense bump under the skin.
Why does a bump get hard? What is physically happening under the skin?
It is a type 5e delayed hypersensitivity reaction. If your body has encountered TB in the past, meaning you have those dormant fortresses in your lungs, your T cells remember the specific proteins of that bacteria.
They recognize the invader.
When those proteins are injected into your arm, your memory T cells sound the alarm and summon a swarm of macrophages to the injection site.
Oh, they all rush to the arm.
The physical accumulation of thousands of these large immune cells packing tightly into the tissue under the skin is what causes it to feel hard and indurated. The clinician then uses a small ruler to measure the exact diameter of that hardness in millimeters to determine if it is a positive reaction.
Let's say the test is positive and further x-rays show the patient has active TB. The pharmacological war we wage against this disease is brutal. The first-line medications include isoniazid, rifampin, pyrazinamide, and ethambutol. Why so many drugs at once?
Because Mycobacterium tuberculosis mutates and develops resistance incredibly fast. If you treat it with only one drug, the bacteria will rapidly evolve to survive it.
So you have to hit it from all sides.
Therefore, standard protocol dictates you must begin treatment with 4 separate medications simultaneously to overwhelm the bacteria's ability to adapt. And because the bacteria grow so slowly and hide inside those thick fortresses, the patient must take these toxic drugs every single day for 6 to 12 months.
The side effects of these drugs read like a horror story. Let's look at rifampin.
Rifampin is a highly potent antibiotic. It physically alters the color of bodily fluids.
How so?
It turns a patient's urine, sweat, saliva, and tears a vibrant reddish-orange color.
Orange tears.
Yes, it will permanently stain contact lenses. Beyond the visual shock, it's a massive enzyme inducer in the liver, meaning it alters how the body metabolizes numerous other medications, rendering things like beta blockers, oral anticoagulants, and oral contraceptives virtually ineffective.
But isoniazid, or INH, has an even wilder systemic interaction. Patients on isoniazid are placed on severe dietary restrictions regarding a chemical called tyramine. What is tyramine and what foods have it?
Tyramine is a naturally occurring compound derived from the amino acid tyrosine. It's found in high concentrations in foods that are aged, fermented, or pickled.
Like what?
We're talking about aged cheeses like cheddar or blue cheese, red wine, soy sauce, yeast extracts, and certain fish like tuna.
So if a patient on isoniazid decides to have a tuna sandwich and a glass of red wine, what happens inside their body?
It triggers a dangerous chemical cascade. Tyramine stimulates the release of norepinephrine, a potent stress hormone that constricts blood vessels and raises blood pressure.
Okay.
Normally, your body uses an enzyme called monoamine oxidase to quickly break down tyramine before it can cause trouble. However, isoniazid acts as a mild monoamine oxidase inhibitor. It stops that enzyme from working.
So the tyramine from the cheese and wine floods the system and isn't broken down.
Yes. The tyramine builds up rapidly, triggering a massive release of norepinephrine. The patient will experience a severe sympathetic nervous system reaction.
What does that feel like?
Intense, pounding headache, flushing of the skin, palpitations, diaphoresis or heavy sweating, and a potentially dangerous spike or drop in blood pressure. It is a miserable and frightening experience, highlighting how deeply these medications alter the body's basic chemistry.
To prevent that apocalyptic scenario, the medical community relies on a surprisingly labor-intensive strategy called DOT.
Directly observed therapy. Because the public health risk of a drug-resistant airborne plague is so unimaginably high, We cannot simply trust patients to remember their pills.
So what do?
DOT programs assign a public health worker or healthcare provider to physically meet with the patient every single day, watch them put the pills in their mouth, and directly observe them swallow every single dose for the entire 6 to 12 months of therapy.
This is wild.
It is incredibly resource intensive, but it is the only proven way to ensure the eradication of the bacteria and prevent resistant strains.
It takes an entire village just to defeat one microscopic wall. And speaking of walled-off granulomas, TB isn't the only disease that forms them. There is a mysterious condition called sarcoidosis.
Sarcoidosis is a fascinating, frustrating immunological puzzle. It's an inflammatory, multisystem granulomatous disease, but unlike TB, it has an unknown etiology.
Meaning they have absolutely no idea what actually causes it. No bacteria, no fungus.
Exactly. The immune system goes into overdrive, recruiting macrophages and building those same dense, fibrous granuloma fortresses we saw in TB, but it appears to be fighting a ghost. There's no identifiable infectious agent.
Who does it affect?
It usually presents in adults between 20 and 40 years of age. While it can affect almost any organ in the body, the skin, the eyes, the liver, the spleen, over 90% of patients have severe thoracic involvement. The granulomas cluster in the lung tissue and the lymph nodes of the chest.
How does a patient even know they have it?
It often has an insidious onset. The patient might just feel generally fatigued or have a mild dry cough. But as the granulomas multiply and the lung tissue responds by laying down scar tissue, the lungs become stiff.
So they can't breathe deeply.
The patient develops restrictive lung disease. They simply cannot expand their lungs fully, leading to worsening shortness of breath. Because we don't know the cause, we can't cure it. We can only try to suppress the immune system with corticosteroids to stop it from building more scar tissue.
Let's look at one final chronic, localized lung threat. Lung abscesses. Just the phrase lung abscess sounds horrific.
It is a severe destructive process. A lung abscess is a localized collection of pus caused by microbial infection. It often develops as a complication of bacterial pneumonia or from aspirating oral bacteria.
Okay, so a pocket of infection.
As the bacteria multiply, they cause tissue necrosis. The lung tissue literally dies and liquefies, creating a cavity filled with necrotic debris, fluid, and purulent material pus.
A pocket of liquefying tissue deep inside the lung. What happens when that pocket gets too full?
The abscess expands, destroying healthy tissue in its path. Eventually, the necrotic process erodes right through the wall of an adjacent bronchus. The cavity ruptures into the airway.
And the patient?
The patient will suddenly begin to expectorate or violently cough up massive amounts of the purulent contents of the abscess. It manifests as copious, foul-smelling, often blood-tinged sputum.
That sounds traumatic.
It is a distressing and dangerous event, as the infectious material can then spread to other parts of the lung, requiring long-term high-dose antibiotics and aggressive chest physiotherapy to clear the cavity.
Okay, let's pull back from the intricate microscopic tissue of the alveoli and the bronchi. We need to look at the packaging, the wrapper that holds this entire fragile system together.
The pleura.
Yes, we're moving to the pleural disorders. We've explored the tubes and the spongy tissue. Now we're looking at the incredibly delicate lining that surrounds the lungs, the pleural space.
The pleura is a brilliantly designed double-layered serous membrane. Imagine a balloon that you've pushed your fist into.
Okay, my fist is in a balloon.
Your fist is the lung. The layer of the balloon tightly touching your skin is the visceral pleura. It wraps the surface of the lung perfectly. The outer layer of balloon, which lines the inside of your rib cage and the diaphragm, is the parietal pleura.
And between those two layers of balloon is the pleural space. But medical professionals call it a potential space. Why potential?
Because under normal physiological conditions, it isn't really a space at all. The visceral and parietal pleura are pressed tightly against each other, separated by only a microscopic gap containing roughly 5 to 15 milliliters of pleural fluid.
What does that fluid do?
This fluid acts as a crucial lubricant. When you inhale and your chest wall expands, the fluid creates surface tension like two wet panes of glass stuck together. The chest wall pulls outward, and the surface tension pulls the lung tissue outward with it, allowing the lung to expand smoothly without friction.
But when that smooth, frictionless system gets inflamed, it causes agony. Let's talk about pleurisy or pleuritis.
Pleurisy is the inflammation of both layers of the pleura. The surfaces become swollen, rough, and covered in an inflammatory exudate. The lubricant fails.
There is a crucial anatomic distinction regarding pain here. If I cut my lung tissue, does it hurt?
The visceral pleura, the layer physically touching the lung, does not have sensory nerve endings. You
Right.
cannot feel it. But the parietal pleura, the layer lining the inside of your chest wall, is incredibly rich in sensory nerve endings.
So if those two layers are swollen and rough, what happens when a patient tries to take a deep breath?
Every time the chest expands, those two inflamed, rough surfaces grind against each other like coarse sandpaper. Because the parietal pleura is hypersensitive, this friction triggers severe, sharp, knife-like pain.
Ow.
The pain is distinctly synchronized with respiration. It catches and intensifies sharply on inspiration and lessens when the patient holds their breath or exhales.
Well, what happens if that inflammation causes the pleural membranes to start weeping fluid? If that tiny microscopic potential space suddenly starts filling up with cups or even liters of liquid?
That phenomenon is called a pleural effusion. It's an abnormal accumulation of fluid in the pleural space. It's vital to understand that a pleural effusion is rarely a primary disease itself. It's almost always a secondary complication, a symptom that something else in the body is feeling.
Think about the physics of the chest cavity. The rib cage is a rigid box. It cannot expand much. If the space between the lung and the ribs fills with a liter of fluid, the fluid has to go somewhere, so it pushes inward.
Exactly. The fluid creates massive external hydrostatic pressure against the soft, spongy lung tissue. The lung literally has no room to expand.
It's being crushed.
The fluid physically crushes the alveoli from the outside in, causing widespread compressive atelectasis. The larger the effusion, the more lung tissue is compressed, and the more severe the patient's dyspnea or shortness of breath becomes.
To fix it, doctors perform a thoracentesis. They stick a needle through the ribs into that fluid pocket and drain it out to let the lung re-expand.
Right.
But they also send that fluid to the lab to figure out why it's there. The lab categorizes the fluid as either a transudate or an exudate. What is the difference, and what does it tell the doctor?
The distinction is critical for diagnosis. A transudate is a clear, relatively watery filtrate of blood plasma. It occurs when the pleural membranes themselves are perfectly healthy, but the systemic factors regulating fluid pressure in the body are out of balance.
Like plumbing backing up.
Precisely. The most common cause is severe congestive heart failure. The left ventricle of the heart fails to pump efficiently, so blood backs up into the pulmonary veins.
Okay.
This increases the hydrostatic pressure inside the pulmonary capillaries to the point where clear plasma is physically forced out of the blood vessels and leaks into the pleural space. The pipes are leaking because the pressure is too high.
In an exudate.
An exudate is fundamentally different. It's thick, cloudy, and rich in cellular proteins and white blood cells. It occurs when the pleural membranes themselves are diseased or actively inflamed.
Due to what?
Things like severe bacterial pneumonia, tuberculosis, or malignant tumors invading the pleura cause the capillary walls to become highly permeable, leaking this thick inflammatory fluid into the space.
The most dangerous iteration of fluid in the chest involves an exudate that has turned deeply infectious. An empyema.
An empyema is the accumulation of thick, purulent, pus-filled fluid within the pleural space. It is essentially a massive abscess filling the cavity around the lung.
How does it get there?
It most frequently develops as a severe complication of bacterial pneumonia or a lung abscess that has ruptured outward.
How does the body react to a lake of pus inside the chest?
The immune system responds with extreme prejudice. It attempts to wall off the infection, much like it does with TB, but on a macro scale.
Building more walls.
Fibrin, a sticky protein involved in blood clotting, begins to coat the pleural surfaces. This fibrin organizes into thick, fibrous peels that stick the visceral and parietal pleura together, creating loculated or walled-off isolated pockets of pus.
So you can't just stick a needle in and drain it out because the pus is trapped in a dozen little honeycomb rooms.
Exactly. A simple thoracentesis often fails because the fluid is too thick and compartmentalized. The fibrous peel can become so thick that it forms a rigid rind around the lung, permanently restricting its expansion, a condition known as trapped lung.
How do you treat that?
Treating an empyema requires prolonged, aggressive intravenous antibiotics and often surgical intervention, inserting large-bore chest tubes to break up the loculations and continuously drain the cavity.
Chest tubes. That is a phrase that signifies a massive escalation in clinical care. It means the body's natural mechanics have failed, and medicine has to intervene with heavy machinery.
It's a turning point.
When the lungs or the pleural space are so compromised that the body is literally starving for oxygen and drowning in toxic carbon dioxide, the medical team has to take over the physical act of breathing. Let's step into the intensive care unit.
The ICU is where we treat acute respiratory failure. This is not a slow decline. It is a sudden, catastrophic, and life-threatening deterioration of the gas exchange function of the lungs. The clinical definition is not subjective. It is based on very specific, alarming arterial blood gas numbers.
Let's lay out the parameters. When does a doctor look at a lab result and declare official respiratory failure?
There are three primary numerical criteria. First is severe hypoxemia, a decrease in arterial oxygen tension, or a PaO2, to less than 60 millimeters of mercury. Normal is between 80 and 100. Below 60, your organs are suffocating.
Okay, PO2 under 60.
Second is hypercapnia, an increase in arterial carbon dioxide tension, or PaSO2, to greater than 50 millimeters of mercury.
Carbon dioxide is the exhaust gas. If it's over 50, the body isn't exhausting the fumes, they're building up in the blood.
And that buildup leads to the third criterion, acidemia. When carbon dioxide dissolves in blood, it forms carbonic acid. The patient's arterial pH drops to less than 7.35.
The blood is becoming acidic.
The blood is literally becoming acidic, which rapidly denatures cellular proteins and stops enzymes from functioning.
PO2 under 60, PaO2 over 50, pH under 7.35. Starving for oxygen, poisoned by exhaust, blood turning acidic. When a patient hits those numbers and is showing physical signs of exhaustion, restlessness, severe tachycardia, confusion, cyanosis, the team has to act immediately to secure the airway.
Securing the airway usually means intubation, bypassing the failing mechanics of the upper airway and providing a direct, secure line into the lungs. The two primary methods are endotracheal intubation and tracheostomy.
Explain the endotracheal tube.
Endotracheal intubation involves passing a specialized plastic tube through the mouth or the nose, threading it precisely past the vocal cords, and securing it deep in the trachea.
Oral versus nasal. Why would they choose one over the other?
The clinical consensus strongly prefers the oral route. Passing a tube through the nasal cavity carries a high risk of trauma to the delicate nasal turbinates and increases the risk of sinus infections.
Makes sense.
But more importantly, the physics of airflow dictate the choice. The oral cavity is larger, which allows the physician to insert an endotracheal tube with a significantly larger internal diameter.
A wider pipe?
A wider pipe is crucial. Poiseuille's law of fluid dynamics tells us that airway resistance decreases exponentially as the radius of the tube increases. A larger tube means the ventilator doesn't have to push as hard to get the air in, and it makes it vastly easier for the nurse to pass a suction catheter down the tube to aggressively clear out those thick, purulent secretions we discussed earlier.
But if a patient's going to be on a machine for weeks or months, having a plastic tube taped to their mouth and shoved through their vocal cords causes permanent damage, that's when they switch to a tracheostomy.
A tracheostomy is a surgical procedure where an incision is made directly through the front of the neck into the trachea, usually just below the larynx. The breathing tube is inserted directly into the windpipe, completely bypassing the mouth, nose, and vulnerable vocal cords.
That seems better for the long term.
It is much more comfortable for the long-term patient, allows for easier weaning, and enables them to eat and potentially speak with specialized valves.
Regardless of how the tube gets in, once it is secured, it is connected to a mechanical ventilator. Let's talk about the incredible physics of these life support machines. How do they actually force a human lung to breathe?
To understand modern ventilation, we have to look briefly at its history. During the polio epidemics of the mid-20th century, we primarily used negative pressure ventilators, famously known as iron lungs.
Those big metal tubes.
These massive metal cylinders encased the patient's entire body up to the neck. The machine acted like a giant mechanical diaphragm. It sucked air out of the cylinder, creating negative pressure around the outside of the patient's chest. This external vacuum physically pulled the rib cage outward,
which expanded the lungs, creating a vacuum inside the chest, drawing air in through the patient's mouth. It perfectly mimicked the natural negative pressure mechanics of human breathing.
Exactly. But iron lungs were bulky, restrictive, and made nursing care incredibly difficult. Today, the modern ICU relies almost exclusively on positive pressure ventilators. These machines completely reverse the natural physics of breathing.
How so?
Instead of pulling the chest open to suck air in, positive pressure ventilators act like a powerful set of mechanical bellows.
They ram the air in.
They force highly oxygenated gas into the lungs under positive pressure. They push the air down the endotracheal tube, physically forcing the airways and alveoli to stretch open during inspiration. Expiration then occurs entirely passively. The machine stops pushing, a valve opens, and the natural elastic recoil of the stretched lung tissue pushes the air back out.
Operating these machines requires mastering an entire language of modes and settings. Let's decode the two major modes, CMV and SIMV.
CMV stands for Continuous Mandatory Ventilation, frequently referred to as assist control ventilation. In this mode, the machine is the absolute master of the respiratory cycle.
It's in charge.
The physician programs a preset tidal volume, say 500 milliliters of air, and a preset mandatory rate, perhaps 15 breaths per minute.
So the machine guarantees the patient gets 500 milliliters 15 times a minute no matter what. What if the patient wakes up slightly and tries to take a breath on their own?
The machine is highly sensitive to the patient's effort. If the patient attempts to initiate a spontaneous breath, creating a tiny drop in pressure, the ventilator immediately senses it.
Does it let them breathe?
But it doesn't just let the patient take a small sip of air. It forcefully responds by delivering the full, preset 500 milliliter volume. Every single breath the patient takes, whether initiated by the machine's timer or triggered by the patient's own effort, is the exact same large mandatory volume. The machine does all the physical work.
It sounds controlling but necessary if the patient is exhausted. How does MMV differ?
SEMV is synchronized intermittent mandatory ventilation. This mode was designed to allow a more natural integration of the patient's own respiratory efforts. Like CMV, it delivers a preset number of mandatory machine breaths at a preset volume. However, the crucial difference lies in what happens between those mandatory breaths.
The intermittent part.
Yes. Between the machine's forced breaths, the patient is completely free to take their own spontaneous breaths. And unlike CMV, the machine does not force a massive volume of air in response.
It just lets them sip.
The patient simply draws in whatever volume their own diaphragm can manage, using the oxygen provided in the circuit. Furthermore, the machine monitors the patient's spontaneous efforts and cleverly synchronizes its mandatory breaths so it doesn't fire a massive pressure wave while the patient is trying to exhale. It prevents the machine and the patient from fighting each other.
By letting the patient take their own breaths in between, SIMV forces the patient's diaphragm to do some work, keeping the muscles engaged. But the most vital setting on any of these modes, the dial that fundamentally alters the efficiency of gas exchange, is PEEP.
Positive end expiratory pressure. Understanding PEEP is understanding the core of critical care respiratory therapy.
Break it down for me.
Consider the alveoli, the wet balloons in a severely diseased lung, like one battling pneumonia or ARDS. When the patient exhales, the pressure in the airway drops towards zero. Without PEEP, those damaged, heavy, fluid-filled alveoli will completely collapse at the end of every single breath.
The balloons just snap shut.
And popping a completely collapsed wet balloon back open on the next breath requires a massive, damaging amount of pressure. It causes sheer stress and trauma to the delicate tissue. PEEP solves this by never letting the pressure drop to zero.
How does it do that?
It is a mechanical setting that maintains a constant baseline level of positive pressure, often measured as 5 or 10 centimeters of water pressure in the airways at the very end of exhalation.
It puts a thumb over the end of the balloon before all the air escapes. It never lets it fully deflate.
Exactly. It creates a continuous back pressure that physically pops the alveoli open throughout the entire respiratory cycle. By keeping thousands of previously collapsed alveoli recruited and open, you massively increase the functional residual capacity of the lung. You are increasing the physical surface area available for gas exchange.
Which means the blood has vastly more time and space to extract oxygen from the air.
And that is critical because it allows the medical team to maintain adequate blood oxygen levels while safely lowering the FiO2, the fraction of inspired oxygen. Pushing 100% pure oxygen into a lung for days is actually highly toxic to the tissue.
Yeah.
PEEP allows us to oxygenate the patient efficiently using much safer, lower concentrations of oxygen.
But saving a life with a ventilator carries immense secondary costs, both to the staff and the patient. One of the major systemic hazards discussed in ICU environments is alarm fatigue.
Modern ventilators are deeply complex computers equipped with hypersensitive alarm systems. They constantly monitor dozens of parameters. They ping, beep, and blare for high peak airway pressure, low tidal volume, high respiratory rate, apnea, kinks in the tubing, or even the patient simply coughing.
They cry wolf constantly.
A single ICU nurse might hear hundreds of ventilator alarms in a 12-hour shift. Because the vast majority of these alarms are transient, self-correcting, or non-lethal, the human brain naturally adapts by tuning them out. This desensitization is called alarm fatigue.
That sounds dangerous.
It's incredibly dangerous because amidst the 100 benign beeps, there will be one critical alarm, a total tube disconnect, or a sudden pneumothorax, and the delayed reaction time can be fatal. Hospitals have to implement strict, standardized protocols for customizing alarm parameters to each patient to reduce the noise and ensure only the truly life-threatening events trigger the loudest alerts.
The psychological toll on the patient attached to that machine is even more profound. Being paralyzed, sedated, and having a machine breathe for you alters the brain. Medical teams combat this with a protocol called the ABCDEF bundle.
Patients who survive prolonged mechanical ventilation in the ICU are at a staggeringly high risk for developing ICU-acquired delirium and later post-intensive care syndrome, or PICS. PICS involves profound long-term physical weakness, severe PTSD, depression, and significant cognitive impairments that closely mimic mild dementia.
Waking up in an ICU, tied to a bed, unable to speak, with alarms blaring 247, the brain just fractures under that stress. So how does the bundle prevent it?
The ABCDEF bundle is an evidence-based, interdisciplinary protocol designed to minimize sedation and maximize human connection. A stands for awakening, and B for breathing coordination.
What does that entail?
This mandates daily sedation vacations. The nurses deliberately pause the continuous infusion of sedatives and analgesics. They let the patient wake up to see if their brain can follow commands and simultaneously reduce the ventilator support to see if they can breathe spontaneously.
They wake them up every day to test the engine.
Yes. C is choice of analgesia and sedation, prioritizing pain control over heavy, coma-inducing drugs. D is delirium monitoring, using standardized assessments to catch acute confusion early. E is early mobility. This is crucial. Even if a patient is intubated and on a ventilator, if they are physiologically stable, physical therapists will get them sitting on the edge of the bed or even walking in the room.
Walking while intubated, that seems impossible.
It requires an entire team managing the tubes, but the physical and psychological benefits of upright mobility are undeniable. And finally, F is family engagement and empowerment, recognizing that the presence of loved ones is one of the strongest grounding mechanisms for a delirious brain.
Let's focus on the breathing coordination, weaning a patient off a ventilator. To a layperson, it sounds simple. The disease is cured, so you just turn off the machine, pull out the tube, and they breathe. But the clinical reality is that weaning is a physically grueling, exhausting ordeal. Why is it so hard to just breathe again?
Because of profound, rapid respiratory muscle atrophy. The diaphragm and the intercostal muscles between your ribs are skeletal muscles, just like your biceps or quadriceps. Their sole purpose is to contract forcefully 20,000 times a day against resistance.
Right.
If you put a patient on a CMV mode ventilator and the machine does 100% of the physical work of expanding the chest for even a few days, those muscles enter a state of disuse.
They realize they aren't needed, so they shrink.
They weaken and atrophy remarkably fast. Furthermore, critically ill patients are in a hypercatabolic state. Their bodies are desperately burning calories to fight infection. If their nutritional intake is inadequate, the body will literally catabolize it, will eat and break down its own diaphragm muscle tissue to harvest proteins for energy.
So the muscles that pull the air in have withered away. Waking up and trying to breathe on your own is like trying to bench press your body weight after being bedridden for a month.
It is an immense physiological workout. The heart rate spikes, the work of breathing increases exponentially. That is why respiratory therapists use careful, step-by-step methods like T-piece trials.
What does a T-piece trial look like?
The patient is disconnected from the mechanical push of the ventilator, but a T-shaped connector is attached to their endotracheal tube to supply a flow of humidified oxygen. The machine is no longer helping them expand their chest. They are completely reliant on their own weakened diaphragm to pull the air in.
They're flying solo.
A nurse or respiratory therapist stands at the bedside and watches them like a hawk. They monitor for signs of exhaustion, rapid, shallow, panicked breathing, a skyrocketing heart rate, a drop in oxygen saturation, or the use of accessory muscles in the neck to heave the chest open.
And if they start struggling?
If the patient fatigues, they are immediately placed back on the ventilator to rest. It is a slow, grueling process of athletic conditioning to build that strength back until they can sustain their own airway for hours at a time.
And unfortunately, sometimes the ventilator, no matter how perfectly calibrated, is simply not enough. We have reached the edge of the clinical map. Let's look at the ultimate failures of the respiratory system. We are talking about ARDS and pulmonary hypertension. What happens when the capillary membrane itself, the very boundary where gas exchange occurs, is fundamentally destroyed?
We are entering the realm of acute respiratory distress syndrome, or ARDS. This is not a specific disease. It is a catastrophic clinical syndrome characterized by a severe diffuse inflammatory process that causes widespread alveolar damage. It is a rapid onset, life-threatening condition.
What triggers it?
It can be triggered by direct injury to the lungs, such as massive smoke inhalation, near drowning, or the severe aspiration of gastric acid we discussed earlier. But it can also be triggered by indirect systemic injuries, massive physical trauma, severe burns across the body, or sepsis, which is a massive blood infection.
How does an infection in the blood destroy the lungs?
It is the body's own immune response tearing itself apart. The systemic insult triggers the release of a massive wave of inflammatory chemical mediators, cytokines, macrophages, and neutrophils that flood into the pulmonary circulation. These chemicals attack the endothelial cells lining the pulmonary capillaries.
The walls of the tiny blood vessels surrounding the alveoli.
Yes, the inflammatory chemicals literally cause the cells lining the capillaries to retract, creating microscopic physical gaps in the vessel walls. The capillaries become extremely leaky.
And what leaks out?
Massive amounts of protein-rich fluid, blood cells, and fibrin rush out of the bloodstream and flood the interstitial spaces of the lung and then pour directly into the alveoli themselves.
The lungs are suddenly violently flooded from the inside.
It is non-cardiogenic pulmonary edema. It isn't caused by heart failure pushing fluid out. It is caused by the physical destruction of the capillary barrier. Furthermore, this highly toxic, protein-rich inflammatory fluid inactivates whatever surfactant is present, and the massive inflammation kills the type 2 cells that make more.
So you have alveoli filled with heavy fluid and no surfactant to keep them open.
The physical characteristics of the lung change drastically. They become incredibly heavy, boggy, and stiff. We say they have severely decreased compliance. The ventilator has to push with dangerous amounts of pressure just to force a tiny breath in. You have widespread alveolar collapse and a massive VQ mismatch.
Because the alveoli are filled with sludge, the oxygen can't reach the blood.
The blood shunts right past the non-functioning alveoli. This results in the hallmark sign of ARDS, severe refractory hypoxemia. Refractory means it does not respond to treatment. No matter how much pure 100% oxygen you push through the ventilator, the patient's arterial blood oxygen levels will remain dangerously low because the physical membrane where the gas exchange happens is too thick, flooded, and broken to function.
This was the terrifying reality at the height of the COVID-19 pandemic. Millions of people developed virally induced ARDs, and the clinical interventions required to fight it are physically extreme. Let's talk about the mechanics of prone positioning.
Prone positioning is a powerful, low-tech intervention that manipulates the physical anatomy of the chest to improve oxygenation. It literally involves flipping an intubated, critically ill, paralyzed patient completely onto their stomach and leaving them in that prone position for 12 to 16 hours a day.
Flipping a patient who has a plastic tube in their windpipe and lines in every vein onto their face sounds incredibly dangerous. Why does lying on your stomach save your life in ARDS?
It comes down to gravity and structural anatomy. When a human lies supine on their back, the massive weight of the heart and the dense mediastinal structures sits in the front of the chest, resting heavily backward onto the lung tissue. Furthermore, in ARDS, gravity causes that heavy, dense, fluid-filled inflammatory exudate to pool and settle in the dependent posterior areas of the lungs, the parts resting against the bed.
So the back of the lungs are crushed by the heart and drowning in fluid.
Exactly. The posterior alveoli collapse completely, but the anterior, front-facing parts of the lungs remain relatively clear and open. By flipping the patient prone onto their stomach, you completely alter the physics.
How?
The heavy heart is now supported by the sternum, relieving the physical compression on the lungs. The dependent fluid begins to shift.
And the healthy, undamaged interior alveoli are now facing the back, where the blood flow is actually richest.
You've got it. Prone positioning optimizes the matching of ventilation to perfusion. It recruits thousands of dormant alveoli, improves lung compliance, and frequently results in a dramatic, life-saving improvement in arterial oxygenation.
But getting a patient into that position and keeping them ventilated with incredibly stiff lungs often requires the most extreme pharmacological intervention in the ICU, the use of neuromuscular blockade.
In severe ARDS, the patient's lungs are so stiff and their body is so starved for oxygen that their primitive brainstem panics. The patient will fight the mechanical ventilator.
What does that mean, fight the ventilator?
The machine will try to push a breath in, and the patient will simultaneously try to exhale or gasp. This patient ventilator dysynchrony creates massive pressure spikes inside the chest, which can literally cause the alveoli to pop, a condition called barotrauma.
So the patient's own panic is destroying their lungs. How do doctors stop it?
They administer potent neuromuscular blocking agents. These are paralytic drugs. They chemically sever the connection between the nerves and the skeletal muscles. The diaphragm stops completely. The patient cannot move their arms, they cannot breathe, they cannot open their eyes. They are entirely dependent on the machine.
But there is a massive, incredibly urgent quality and safety nursing alert attached to the use of paralytics. This is the ultimate nightmare scenario.
It is arguably the most critical safety alert in critical care pharmacology. Neuromuscular blocking agents paralyze the skeletal muscles, but they do absolutely nothing to the central nervous system. They possess zero analgesic properties, meaning they provide no pain relief, and they possess zero amnestic or sedative properties. They do not put the brain to sleep.
If a nurse hangs a bag of paralytics and forgets the other medications,
the result is sheer psychological torture. A paralyzed patient should be wide awake, perfectly lucid. They would feel the excruciating pain of the endotracheal tube in their throat, the sharp burn of IV lines, the intense pressure of the ventilator forcing their chest open.
That's horrifying.
They would feel the visceral terror of being completely unable to breathe or move, and they would be utterly unable to communicate it. They cannot speak, cry, or even flutter an eyelid to beg for help. They are a fully conscious brain locked inside a chemically frozen body.
I can't even imagine.
Therefore, the administration of deep, continuous sedation and potent analgesia pain medication is an absolutely mandatory, non-negotiable prerequisite to using paralytics. The nurse must continuously monitor the depth of paralysis using a peripheral nerve stimulator, often applying a train of 4 electrical shock to the ulnar nerve to measure thumb twitches. But simultaneously, they must obsessively ensure that the sedation drips never run dry and that the patient's brain remains deeply, safely unconscious.
The immense granular responsibility of the critical care nurse cannot be overstated.
Way.
We've looked at the failure of the alveoli. The other massive crisis in this section involves a different kind of pressure failure. We are shifting from the airways to the blood vessels. Pulmonary hypertension.
Pulmonary hypertension, or PH, completely shifts our focus. The lung tissue itself might be relatively healthy, but the intricate web of blood vessels surrounding the alveoli is failing. It is characterized by pathologically elevated pressure within the pulmonary arterial system.
Let's look at normal physics first. The right side of the heart pumps deoxygenated blood into the lungs, and the left side pumps oxygenated blood to the whole body. The right ventricle is much smaller and thinner than the left, right?
Correct. Under normal conditions, the pulmonary vascular bed, the network of vessels inside the lungs, is a remarkably low-pressure, low-resistance system. It is highly compliant. The right ventricle doesn't have to push very hard to gently circulate blood through the lungs to pick up oxygen.
But in pulmonary hypertension, that easy flow hits a wall.
Various triggers, whether it is chronic lung disease, chronic blood clots, or genetic mutations, cause severe vascular injury. The walls of the tiny pulmonary arteries react by thickening, stiffening, and constricting. The smooth muscle hyperproliferates. The vast, compliant vascular bed is physically obstructed or destroyed. The resistance to blood flow skyrockets.
Think about drinking through a straw. Normally, your heart is pushing blood through a wide, easy garden hose. In PH, the body caps the hose and replaces it with a tiny, rigid coffee stirrer.
That is an excellent mechanical comparison. The right ventricle of the heart, which was only designed to push against the low resistance of a garden hose, suddenly has to forcefully pump massive volumes of blood against the extreme resistance of that tiny coffee stirrer.
And skeletal muscle grows when it works hard. Does the heart muscle do the same?
Yes, but in the heart, that growth is deadly. To overcome the extreme resistance, the right ventricle works furiously. The myocardium, the heart muscle hypertrophies, it enlarges and thickens, but eventually it reaches its limits. The muscle cannot meet the oxygen demands of its own excessive workload. The right ventricle dilates, weakens, and ultimately fails.
The heart breaks itself trying to push blood through the broken lungs.
This specific terminal condition, right-sided heart failure, caused entirely by pulmonary hypertension, is called cor pulmonale.
And the symptoms as that right heart fails sound absolutely miserable.
The clinical presentation is devastating. The primary symptom is severe dyspnea with even minor exertion. The patient might experience syncope or fainting because the right heart simply cannot push enough blood through the lungs to reach the left heart, meaning the brain doesn't get enough oxygen. But the most visible signs occur when the right ventricle fails completely. Because the pump is broken, the venous blood trying to return to the heart backs up into the systemic circulation.
The plumbing floods backwards into the body.
The patient develops massive peripheral edema with severe swelling in their legs and ankles. Fluid backs up into the abdomen, causing ascites. The liver becomes engorged with backed up blood and becomes painfully enlarged. It is a slow, suffocating failure of the cardiovascular system.
Treating it involves highly specialized medications, right? Things that forcibly dilate those stiff blood vessels.
The pharmacology is highly advanced. Depending on the classification of the pH, patients might require complex therapies like prostanoids. These are potent vasodilators that often require continuous 204/7 subcutaneous or intravenous infusion through specialized central lines, just to keep the pulmonary vessels relaxed enough for the right heart to survive.
It is a devastating progressive reality, which serves as a grim transition to our next section. We're moving away from the sudden, acute crises of the ICU and looking at the slow-moving, irreversible disasters caused by our environment. Section 7, Environmental Hazards and Malignancy. Let's start with occupational lung disease, specifically a category called the pneumoconiosis.
Pneumoconiosis is a broad clinical term referring to chronic, non-neoplastic lung disease caused by the inhalation of inorganic dust over a long period. We are looking at the consequences of industrialization on human biology. The three major classic forms are silicosis, caused by inhaling crystalline silica dust, asbestosis from inhaling asbestos fibers, and coal workers' pneumoconiosis, colloquially known as black lung disease.
We talked about macrophages earlier, the cellular garbage trucks that eat invaders like TB. The mechanism of destruction in these dust diseases goes right back to those same cells, doesn't it?
It is a tragic cellular cycle. A miner, construction worker, or shipbuilder inhales this fine, microscopic mineral dust for decades. The particles are so small they reach the deepest terminal alveoli. The immune system detects the foreign debris and dispatches the macrophages to clean it up. The macrophage engulfs the silica or asbestos particle.
But these aren't biological bacteria. They are microscopic rocks and glass.
Precisely. The macrophage's digestive enzymes cannot break down inorganic minerals. The jagged, toxic dust physically destroys the macrophage from the inside out.
The garbage truck chokes on a rock and dies.
When the macrophage dies and ruptures, it doesn't just release the indestructible dust particle back into the lung tissue, it also spills a massive load of inflammatory chemical mediators and toxic enzymes. This chemical distress signal summons waves of new macrophages to the site. They too engulf the same dust particle, fail to digest it, and die, releasing more toxins.
It's an endless, self-sustaining loop of cellular death.
And the ultimate consequence of this chronic inflammation is fibrosis. The constant cycle of injury and death triggers fibroblasts to lay down dense webs of collagen and scar tissue around the dust deposits. Over decades, the delicate, stretchy, spongy lung parenchyma is replaced by thick, rigid, non-functional fibrotic scar tissue. The lungs become stiff, compliance drops drastically, and gas exchange becomes impossible. The damage is permanent and irreversible.
And we tend to think of black lung or silicosis as tragedies of the 20th century, affecting miners from 50 years ago. But the biological vulnerability of our lungs to the environment hasn't changed. We are seeing a new generation of occupational lung disease in highly modern contexts, specifically regarding military veterans.
It is a profound, unfolding public health issue. A massive number of military veterans who served in the conflicts in Iraq, Afghanistan, and elsewhere in the Middle East are presenting with severe, unexplained respiratory disorders. During their deployments, these service members were exposed to uniquely toxic environments. They breathed in the particulate matter from massive desert sandstorms, but more critically, they lived and worked near massive open-air burn pits.
Burn pits. Literally digging a hole and setting the base's trash on fire.
Massive amounts of waste plastics, medical waste, rubber, chemicals, electronics, and human waste were incinerated daily using jet fuel as an accelerant. The incomplete combustion produced dense, toxic plumes of particulate matter, dioxins, and aerosolized heavy metals.
And the soldiers inhaled that cocktail every day.
And just like the silica dust, those toxic microparticles deposited deep in their alveoli, triggering chronic inflammation and cellular damage. Many of these young, previously healthy veterans are now suffering from conditions like constrictive bronchiolitis, a rare and severe disease where the smallest airways become permanently scarred and narrowed. It proves that our lungs remain entirely, painfully at the mercy of the air we are forced to breathe.
Which leads directly to the deadliest environmental outcome in pulmonary medicine, lung cancer or bronchogenic carcinoma.
The epidemiological statistics surrounding lung cancer are incredibly sobering. Lung cancer is the leading cause of cancer-related deaths among both men and women in the United States. To put the mortality into perspective, more people die of lung cancer annually than of colon, breast, and prostate cancers combined.
The medical community broadly divides lung cancer into two main categories based on the microscopic appearance of the cells, small cell and non-small cell, and the survival rates based on data from the SEER stages. The surveillance, epidemiology, and end results program are grim.
They are stark. For non-small cell lung cancer, which accounts for the majority of cases, if the tumor is localized, meaning it hasn't spread outside the lung, the 5-year survival rate is around 60%. But if it has distant metastasis, meaning the cancer cells have spread through the blood or lymph to the brain, bones, or liver, that 5-year survival rate plummets to a mere 6%. For small cell lung cancer, which is an aggressively fast-growing neuroendocrine tumor, the localized 5-year survival is 29%, and the distant metastasis survival rate is a staggering 3%.
Now, obviously, smoking tobacco is the primary driver here, responsible for roughly 85 to 90% of all lung cancer cases. When a doctor is evaluating a patient, how do they actually quantify and standardize that smoking risk? You can't just write "smokes a lot" on a chart.
Medical professionals track and quantify this exposure using a standardized metric called pack years. It is a simple but powerful mathematical formula designed to measure cumulative exposure to tobacco toxins over a lifetime. You take the average number of packs of cigarettes the patient smokes per day and multiply it by the total number of years they have smoked.
So if a patient comes in and says they have smoked 2 packs a day for the last 15 years,
the calculation is 2 packs multiplied by 15 years, equating to a 30-pack year smoking history. This specific number is critical because it dictates clinical guidelines. For example, the U.S. Preventive Services Task Force strongly recommends annual early screening with low-dose CT scans for adults between the ages of 55 and 80 who have a 30-pack year history and currently smoke or have quit within the past 15 years. Catching the tumor while it is still localized is the only real chance for a surgical cure.
and if they do find a localized tumor, surgery is often the primary weapon. The text details various thoracic surgeries. There's a wedge resection, which is taking out a small pie-shaped piece of tissue, a lobectomy, which is removing one entire anatomical lobe of the lung, and the most extreme, a pneumonectomy, which is the surgical removal of an entire right or left lung.
It is a massive surgical undertaking. And interestingly, removing the right lung carries a significantly higher physiological risk than removing the left. The right lung has 3 lobes compared to the left's 2. It is physically larger and contains a much more extensive vascular bed. Removing it puts a massive sudden strain on the right ventricle of the heart as it tries to redirect all its blood flow into the single remaining left lung.
But there is a fascinating life-or-death detail about the post-operative nursing care for a pneumonectomy. If a patient has just had their entire right lung removed, the nurse must absolutely never turn that patient completely onto their unoperated, healthy left side. Why?
It comes down to the raw physics of the chest cavity. When a surgeon removes an entire lung, they leave a massive empty void in that side of the chest. It is a hollow cavern. If the nurse rolls the patient completely onto their good, unoperated side, gravity violently takes over.
The organs literally fall into the hole.
Yes. The remaining healthy lung, the heart, and the great vessels will physically shift across the midline of the chest cavity and fall into the empty space. This catastrophic anatomical displacement is called a mediastinal shift. It physically compresses the remaining healthy lung tissue, preventing it from expanding. Worse, it violently twists and kinks the vena cava and the aorta, the massive blood vessels attached to the heart. This cuts off blood return to the heart and leads to rapid, often fatal cardiovascular collapse.
So how do you position them?
The patient is carefully positioned flat on their back or tilted slightly toward the operated empty side. Over the following weeks and months, the body will naturally fill that massive empty space with serous fluid, which eventually consolidates and solidifies into a dense, safe, fibrous mass, permanently stabilizing the chest cavity.
That is wild. The physics of pressure, gravity, and structural integrity dictate absolutely everything in the chest. Which brings us perfectly to our final section, where those very physics are violently interrupted from the outside. The physics of trauma. We are looking at blunt and penetrating injuries and the mechanical plumbing used to fix them. Let's start with blunt force trauma and a devastating condition called flail chest.
Flail chest is a terrifying, mechanically complex complication of severe blunt force trauma, most commonly seen when an unrestrained driver slams their chest violently against a steering wheel in a high-speed motor vehicle collision. By clinical definition, it occurs when 3 or more adjacent ribs are fractured at 2 or more distinct sites along the bone.
Imagine a large camping tent. Your ribs are the structural support poles that keep the tent taut and open. If you take a sledgehammer and smash 3 adjacent poles in 2 different places, you kick out the middle supports. That entire section of the tent is no longer structurally sound. It is completely disconnected from the frame. It just flaps uselessly in the wind. That is your flail segment.
A very accurate and visual analogy. You have created a free-floating segment of the chest wall. It is entirely disconnected from the mechanical stability of the rest of the rib cage. And because it is disconnected, it falls victim to a terrifying physical phenomenon known as paradoxical Pindeleft movement.
Let's track the mechanics of a single breath. What happens when the patient tries to inhale?
Let's follow the pressure. Normally, when you inhale, your diaphragm muscle drops downward. This creates a strong negative pressure vacuum inside your chest. Your intact, rigid rib cage expands outward to pull the air in. But if you have a flail segment, that free-floating chunk of broken ribs, it has no structural strength. The powerful negative vacuum inside the chest violently sucks that broken segment inward during inhalation.
The rest of the chest expands outward, but the broken piece sucks deep into the lung tissue.
Yes. It moves paradoxically opposite to the rest of the chest. Because the segment collapses inward, the underlying lung tissue cannot expand. It drastically reduces the tidal volume and the amount of fresh air drawn into the lungs. Then the cycle reverses. When the patient exhales, the diaphragm relaxes and pushes up, creating positive intrathoracic pressure. The intact chest wall naturally recoils inward, but that positive pressure violently pushes the broken flail segment bulging outward.
The chest is literally moving in opposite directions simultaneously. It's an internal tug of war.
Exactly. The flail segment sucks in, then bulges out. This paradoxical motion completely destroys the mechanical efficiency of ventilation. It increases dead space, meaning the patient is just shuffling stale, unoxygenated air back and forth between the lungs without actually exchanging it with the outside atmosphere. Furthermore, the violent back and forth motion shifts the mediastinum, the heart and great vessels, back and forth with every breath, severely compromising cardiac output. It is exhausting, agonizing, and highly lethal without immediate mechanical ventilation to stabilize the chest from the inside with positive pressure.
The other major traumatic consequence, whether from a broken rib puncturing the tissue or a bullet piercing the chest, is the pneumothorax. Air in the pleural space. We talked about pleural effusions earlier, where the space fills with fluid. This is when the vacuum seal is broken by air. There are 3 types: simple, open, and tension. A simple pneumo is a collapsed lung, maybe a small blister or bleb on the lung surface popped. An open pneumo is a penetrating wound, a sucking chest wound where you can literally hear room air rushing in through a hole in the ribs. But a tension pneumothorax is the ultimate heart-stopping emergency.
In a tension pneumothorax, the pleural space is breached either by a lacerated lung leaking air outward or a chest wall wound letting air inward. But crucially, the damaged tissue creates a one-way tissue valve flap. When the patient inhales and creates negative pressure, the flap opens and air rushes into the pleural cavity. But when the patient exhales, the positive pressure pushes the tissue flap closed. The air cannot escape.
The trapped air builds up. Every single panicked breath the patient takes pumps more and more air into this trapped, invisible pocket.
The tension, the positive pressure of the trapped air builds immensely and rapidly. It quickly crushes and completely collapses the lung on the affected side. But the danger doesn't stop with the lung. Because the chest is a closed, rigid box, as the pressure continues to rise exponentially, it physically pushes the entire mediastinum, the heart, the massive aorta, the vena cava, and the trachea violently over toward the unaffected side of the chest.
You can literally see the patient's windpipe shift to the side of their neck. And if the heart is being crushed and pushed out of place by this massive, invisible pocket of air pressure.
The physical compression causes catastrophic cardiovascular failure. The vena cava, the large vein returning blood to the heart, is physically kinked shut by the pressure. Venous return to the heart drops to 0. If the heart cannot fill with blood, it has nothing to pump. Cardiac output plummets instantly. Blood pressure crashes.
The electrical system of the heart might still be firing perfectly, but there's no blood moving.
That is called pulseless electrical activity. The heart is trying to beat, but it is physically crushed by air. The patient will die in minutes unless a medic or doctor performs immediate needle decompression, shoving a large hollow needle directly through the chest wall to puncture the pocket, vent the trapped air under pressure, and allow the heart to unkink and refill.
And whether it is an emergency needle decompression for a pneumothorax, draining blood from a hemothorax, or managing the aftermath of a massive thoracic surgery, doctors eventually have to reestablish that vital, continuous negative pressure vacuum inside the chest. They do this using chest drainage system.
Yes, large bore plastic chest tubes surgically inserted between the ribs and connected to closed drainage systems. The technology has evolved, but the underlying physics rely on brilliant, simple fluid dynamics. There are two main types: traditional water seal systems and newer dry suction systems.
Let's talk about the traditional water seal system.
Yeah.
It is literally just using a column of water to act as a physical one-way valve.
It is an elegant application of physics. The tube exits the patient's chest and connects to a plastic chamber system. The vital component is the water seal chamber, which is filled with exactly 2 centimeters of sterile water. The tube from the patient sits just below the surface of this water. When the patient exhales or coughs, the positive pressure in their chest pushes the trapped air or fluid down the tube. The air bubbles up through the water and escapes out of a vent into the room.
But when the patient inhales, creating negative pressure inside their chest, why doesn't room air rush back up the tube and collapse the lung again?
Because of the water. When the patient inhales, the negative vacuum tries to pull air backward up the tube, but instead of pulling free air, the vacuum simply pulls a small column of water slightly upward inside the tube. The weight of that 2 centimeters of water creates just enough physical resistance to counteract the negative pressure of the breath. Air cannot travel backward through the water seal. The vacuum of the chest is protected.
Nurses monitor this closely by watching for something called titling. The water level inside the tube literally bobs up and down with every breath the patient takes. It is a direct visual confirmation that the plumbing of the chest is patent and connected.
Yes, the water rises on inspiration and falls on expiration. If they need to actively pull fluid out faster, they use a third chamber connected to wall suction, which regulates the gentle pull based on the depth of the water in that third chamber, or in newer models, a mechanical dry suction dial.
But the clinical literature provides a crucial life-saving emergency protocol regarding these chest tubes that everyone working near them must memorize. Imagine you are helping a patient move from their bed to a chair. They trip, the tubing catches, and the chest tube accidentally completely disconnects from the heavy plastic drainage machine. The tube sticking out of the patient's chest is suddenly opened directly to the ambient room air.
That is an immediate life-threatening emergency. The protective water seal is gone. The moment the patient inhales, the massive negative pressure inside their chest will suck room air violently straight through the open tube and directly into the pleural space. They will instantly develop an open, sucking pneumothorax, and the lung will collapse in seconds.
So what is the immediate physical intervention? You can't just put your thumb over it.
You utilize the basic physics of the water seal on the fly. If the tube disconnects and the machine is broken, the nurse must instantly grab the open end of the chest tube and submerge it deep into a bottle or cup of sterile water or sterile saline.
You literally just dunk the open tube into a glass of water.
Yes. By immersing the open end of the tube into an inch or two of sterile fluid, you instantly create a makeshift temporary water seal. If the patient exhales, the trapped air in their chest can push down the tube and bubble out through the water, but when they inhale, the negative pressure pulls the water up into the tube, creating a physical block that prevents room air from entering. It protects the negative pressure environment and prevents the lung from fully collapsing until a brand new sterile drainage system can be assembled and attached.
It is truly amazing. We build these billion-dollar intensive care units with highly advanced pharmacological paralytics and computerized ventilators, but the entire foundation of the respiratory system and our ultimate ways of saving it just come down to mastering basic plumbing, fluid dynamics, and pressure.
It's all plumbing and pressure.
So what does this all mean for us? Let's synthesize this incredible journey. We started at the absolute microscopic level, watching a single tiny mucus plug steal the air from a wet balloon, causing it to collapse. We tracked how a simple hospital bed can create a perfect storm of respiratory failure. We watched inflammatory exudate flood the train station of the alveoli, creating a deadly mismatch of blood and air. We mapped the silent, decades-long cellular siege of a tuberculosis granuloma and the extreme chemical warfare required to break its waxy walls. We saw how a computerized machine can violently push life into a paralyzed patient whose lungs have turned to stiff, leaky sponges. and how a steering wheel can shatter the structural integrity of the ribs, forcing the chest to tear itself apart with every breath. The human respiratory system is an absolute continuous marvel of physics, chemistry, and biology, constantly, desperately fighting to keep us oxygenated in a hostile world.
It is a profound and delicate balance, and studying the specific clinical landscape shows us just how incredibly responsive and, frankly, how deeply vulnerable our lungs are to every tiny environmental change. Whether it's the specific spike protein of a microscopic virus, the jagged edge of an inhaled silica crystal, the acidic burn of gastric juice, or the toxic reticulate matter of a military burn pit, the lungs react. They inflame, they scar, they collapse. They are the only internal organ we possess that is in constant, massive, direct contact with the outside world.
Which brings up a final, lingering thought to explore.
As we look at the trajectory of respiratory health, our atmosphere is rapidly filling with new, highly complex pollutants. We are dealing with the long-term fallout of industrialization, the modern chemical exposure of veterans, and we are even seeing entirely new severe inflammatory syndromes like EVALI, the acute destructive lung injury directly associated with aerosolized vaping chemicals. Our environment is evolving to become more chemically hazardous to delicate tissue. It raises a fascinating and somewhat dystopian question. If our lungs are this fundamentally fragile and our environment is becoming this toxic and unpredictable, will medical technology eventually be forced to bypass the lungs entirely?
You mean taking the job of gas exchange out of the chest?
Yes. We already utilize ECMO, extracorporeal membrane oxygenation, in extreme ICU scenarios, literally pumping a patient's blood out of their body, running it through an artificial mechanical lung to oxygenate it, and pumping it back in. Will we see a future where that kind of technology becomes not just a last resort, heroic measure, but a miniaturized necessary implant? Will we eventually have to artificially oxygenate our blood outside the vulnerable tissue of the alveoli simply to keep pace with the hazards we are inhaling?
It is a wild, slightly terrifying thought. Bypassing the biological balloons because the air itself has become too toxic for the tissue to handle.
Something to think about.
Well, take a deep breath right now. Feel that negative pressure, pull the diaphragm down. Feel the air rush in. Appreciate the magnificent, fragile, invisible machinery making that physical exchange happen inside your chest right this second. Thanks for joining us for this deep dive, and we'll see you on the next deep dive.